is a 70-year-old female who happened to be housebound, and the fragility score was high. She came with a non-STEMI referred by my good friend, Dr. Rotatori, who's in the audience. And he, a very smart way, he had a peak troponin of 17. He go ahead and did the cath. Now, before that, we see the EKG is mostly an anterior injury, although she also has Q waves inferiorly, suggesting that this LV is probably hit before, and the TE actually show it. Ejection fraction was 20%, akinetic. The rest of the left ventricular wall motion was hypokinetic, and she has moderate MR. So it is interesting that the MRI, which was actually done by the surgeon, the patient was referred to the surgeon, and the MRI shows that it's not that big. The MI was only 16% and was subendocardial. So there was significant viability in the LAD, CIRC, and RCA territory. Let's see the angiograms. This is the diagnostic cath, very bad ventricle. You already saw that. RCA is non-dominant. And then we have this anatomy of a super big circumflex with a large LPL, which is severely diseased. And also, you see in the LAD territory, diagonal, two diagonals in trouble. And the LAD has this double lumen in this proximal segment. It's diffusely diseased. In the LAO-cranial, you can see it better, that the disease is extensive. And also, the dominant circ is occluded distally. So the left PDA is also occluded. That shows in the Q waves in the inferior leads. There was another picture here for the first diagonal, second diagonal, and the LPL, distal PDA also occluded. So the decision was made after the MRI was positive. There was some discussions. Very bad ventricle, fragility score very high, housebound. The patient was rejected from surgery. So we ended up fixing this. The fellow was started, as we always do. Our fellow started the procedure. Very simple approach, just a straightforward, LAD. We start with the LAD and then what we get. But when I realized the wire was not in the right place. So there we go. It was, he went through the other side, and it took me a little bit, but it was easy actually leaving the wire on the dissection plane, put another whisper wire, and I don't know, sometimes it's better to be lucky than good. And there we go. So we had the LAD diagonal reconstructed. This is the dual stenting. And then I focused on the circ, which was very difficult because of the tortuosity. A big vessel, but very tortuous. Ended up with a good result at the end, both in the LAD and the circ. So with this, I open for discussion. Bad ventricle, good viability. Anybody will have done differently.
You have a follow-up echo, Pedro?
Go ahead.
Do you have a follow-up echo?
Yeah, I actually, she had some AFib, like at day number 3, and the AFib was transitory. She converted to normal sinus rhythm, and she's doing good so far. So we expect these ventricles to improve because they have viability, but it remains to be seen. The other issue is if you discharge these patients with a vest, if you actually do premature EP studies, or if you just if they have some, for primary prevention is an issue because the vest is always a problem. For secondary prevention is easier, so you go ahead and put the AICD. This is another issue for discussion.
So Pedro, nice case. What was the ejection fraction and the hemodynamics?
24% by MRI and 20% by echo.
And so and I noticed you used Impella obviously to get through the case, and so this would have been a perfect case for the Protect 4 trial. So we've just started a large randomized trial of Impella-supported versus non-Impella-supported high-risk PCI cases like this, complex anatomy, ejection fraction less than 40%, randomized to either get Impella CP versus either balloon pump or nothing. And one of the things we have in that trial is a viability sub-study to answer this exact question that you've got, where we get a baseline and a 6-month CMR. So we'll see if that viability, unlike in the Stitch trial where viability basically predicted absolutely nothing, we'll see if that's really the case when you do a very good viability sub-study. So Samin Sharma is the head of our technique committee, and so this would have been a perfect case for Protect 4 if we had started at Sinai.
That sounds great. And as Dr. Colombo said yesterday, having the impellas when you are in trouble is a virtue, because the impella is solid rock stability, specifically when you need it most. Probably 1 out of 10, we really need it because non-reflow, bad ventricle, dissection. But certainly doing these cases with no support doesn't make much sense. Yeah.
Well, we'll find that out.
Yep.
That's why we're doing
It's
the trial.
randomized, yeah.
I try to get through a couple quickly. 66-year-olds, ejection fraction of 15%. Lots of risk factors as an atretic lima, severely calcified proximal LED, very complex, tortuous. So an impella is in place, and you can see that not only is there calcium, but there is an aneurysm right in the middle of that calcium. We think it was because of the previously placed lima. So difficult to get into. Here's the other view in the cranial LAO. The problems, of course, are wire. Once you get into the aneurysm, it's very hard to get out. Regular wires didn't work. Specialty wires didn't work. Try to reverse loop here. This is a 360 inside of the aneurysm. Try to come out the other end at a slightly different angle. I mean, the question is, what do you do when you have something like this? And this is an example, again, of a non-CTO, but adapting a CTO strategy and approach. So you're going through dissection reentry. This is not a traverse catheter, but it would have been nice. Eventually getting it into the distal portion. Now you face the problem that you've seen in some of the other cases today. What kind of microcatheter can I get through to get this out? And the answer was nothing worked. So we got as close as we could, kind of bring the wire back and forth a few times, create a lumen, and eventually get a rotablator wire down. And again, I don't use a lot of 125s, but this is the one where I used it and jacked it up to 200,000 RPMs just to try to get through this heavily calcified lesion. And this is the end results. So, I mean, my topic really is to expand upon the previous debate that there are clearly some types of cases that you have to have atherectomy to work with.
So how'd you get the rotablator wire down if you couldn't get a microcatheter?
Get the microcatheter down as far as you can.
Okay, so you
take the wire and sort of create and daughter out a lumen for yourself, and then try to work with it as best you can. Okay. It's challenging. It sounds easy, but it's challenging. Dr. Mehta?
John, great case. You had any concerns, and I'm sure you passed the rotablator across the aneurysmal segment?
Yes, very much so. But we looked at it in multiple angles. Obviously, I couldn't IVUS this, couldn't get anything down to begin with. But in the multiple views, I had 360 of calcium, and it seemed to be external to where the wire was, kind of a poor man's IVUS, if you will, to make sure that I've got enough buffer on either side to pass a rotablator burr.
Right. The reason I mentioned is, with a little less lucky outcome with the wire bias, you could.
It could, but he's post bypass, so we obviously have a fibrotic rind. Should I ever get a little bit too deep, it should be able to confine any kind of perforation.
Very good.
So you also have lithotripsy as an option, but it's hard to know what would be with an aneurysm, a true aneurysm, what would be safer.
Yeah,
I just don't know. Orbital atherectomy also is an option, but then you're creating a big orbit in an aneurysm. So I don't know which of those would be safest. And I agree, it probably depends a lot on the wire bias.
Yeah, the main thing on this one was we just couldn't get anything through, and I didn't think orbital would get through that distal portion as a non-front cutter.
You may have to start with a small burr, and then go ahead and get the.
It would be a stepwise progression. Right. I agree.
Look, I think all I can summate here is that everything else here, anything could be tried, probably except a cutting balloon.
Yes, agreed.
Very good. I think the 1 to 5 did a fantastic job. Wiring was very tough, but the case is a beautiful case. Let's move with the second case.
Second case. This is a chronic total occlusion of the mid-LED in a symptomatic patient. Here you can see the dual injection. You already get a feel before the injection that there's 360 of calcium. You can see the up and down portion. We were lucky it didn't cross primarily. Again, this was a dissection reentry. The microcatheter is a Mamba catheter that gets down there. There's a distal injection to show that you're intraluminal. And this is meant to demonstrate one significant feature. Balloons are going down. Each one of them ruptures, 4 of them. up to 35 atmospheres at some point. Still doesn't expand. So this is what we call a granuloplasty. Still not expanding. There's the 4 balloons, all of them rupture. What do you do at this point?
So you have an anterograde approach.
Yeah.
Why did you wait and rupture 4 balloons?
Good point. It seemed like it was going to yield, but it didn't. I tried, there are different types of polymers that are more resistant, and we just went up the scale from different NC balloons, and then a NC Sapphire is actually one that's a little more durable, more like Kevlar, and that didn't work either. So here you're converting to a rotoblader. Okay, case done, right? The next balloon goes down after rotoblader, and that ruptures.
That's a 1-5 burr.
That's a 1-5 burr.
1-5.
1-5 burr. Now the balloon expands a little bit better than the previous ones, but I still have a resistant area.
So well, you probably have the dreaded, calcified spicule or calcified nodule, and one if you imaged, you'll really learn what's going on. And after the 1-2-5 burr, you should be able to do that. But the other things are, you don't have an OPN balloon, of course. That's the balloon that might do this. Go up to 40 to 45 atmospheres, and also has a much better burst profile. The other thing, though, is if I try to do these lesions with a balloon, I use a short balloon, very short, non-compliant balloon, because you will get some dog boning even with very non-compliant balloons on the end. So if you really concentrate the force with a short balloon, it helps. But you clearly need a bigger burr or an IVL catheter or something more to.
Very good. So this is a good example. This is like the first IVL catheter we used. And what's amazing is that at 4 atmospheres, after about 40 pulses, it completely expands. So this is an example, and I think that if you look at the sonic energy that's distributed to the vessel wall, it sometimes translates out to something like 50 atmosphere inflations, something of that nature in terms of its energy. So a good example of how to move, calling it rototripsy. Clearly I don't think, I know Dr. Waxman mentioned that IVL may take over a lot of these calcified lesions, but there's still lesion preparation that has to take place because the balloon will track, but it's not your best tracking balloon. You still have to do some preparation to get there and expand it, and as a result, you get that result. Comments on that?
That's a final stent of 4-row stent, or
yes.
Okay.
One quick one here. This is a challenging case. Previous CABG 5 years ago, now with a non-STEMI, sent to us from an outside hospital, multiple high-grade lesions in a very tortuous right coronary.
So you have like an early bifurcation? Is that what it is?
Yeah. You have you have an RV marginal branch that is really super marginal and has multiple bifurcations. And of course, it's right there at the takeoff of where your highest grade lesion is in the vessel. So when you go ahead and try to wire this, where's the wire going? This is my best fellow saying, I can do this. And of course, it's extraluminal, and it shuts down. It took another 15, 20 minutes to put a bend on a hydrophilic wire with with a gram tip load, a little bit more than what we're used to get it down distally and to get a microcatheter down there. So how would you like to proceed from here? Very tortuous, high-grade calcium.
I think 1-2-5 burr. Huh?
Well, I was concerned about the tortuosity. You've got 3 90-degree bends in here. And so we did try to take balloons. And you end up with a lot of dissections, and you get a balloon that does not go down distally. That mid-segment was never approached with a balloon despite the backup and support of a guide extender. So, Pedro, you're right. At some point, you got to say, I'm going to cast all caution to the winds. Again, it's a post-bypass patient. In the worst case, I could recover, hopefully, if there's some kind of minor perforation. But you've got to take a burr down here because it's not going to happen any other way. So
otherwise
here is
a road of regret. Right?
And it's just going at the beginning very slow, I guess, at the beginning.
Yeah, very, very slow at the beginning.
Very slow.
These are the polishing runs. Obviously, I didn't give you the beginning.
Yeah.
This is not the way it yielded. It just took a good 2 to 3 minutes of intermittent burring just to get past that distal lesion. And of course, it's still a bit of a challenge. You've got to you probably don't even want to look at this after you do a rotablator on a heavily calcified tortuous lesion, but this is what it looks like. There's lots of complex guttering, what looks like dissection planes, very similar to what Dr. Keeney showed you earlier in the day, only this is over a longer period of tortuous segment. So, but it does do the job. I mean, it does break it up enough to allow you to deliver something, and you fight with a little bit, but eventually you get a result that looks a little bit like this. You have to step almost the entire right corner here.
John, how would you, just as a matter of speculation, how do you think a 1.5 burr would have managed here? Because often really, and Dr. Colombo is here, I could ask him also. I mean, majority of the cases, 1 to 5 burr is truly placebo plus. This
is not placebo. This is the real deal. These are the only 1.25 burrs I've used all year. And it was for a specific reason. And that is either I'm dealing with something that I'm very worried about perforation because I'm close to the edge on the first case. And in this case, I'm close to the edge because I'm dealing with a lot of tortuosity. And I know I'm going to gutter. And if I bias too much and have too big a burr pushing it through, remember, this is a 3 millimeter run. This is a 3-minute run of 20-second intervals. A 1.5 burr, might push me into, I need a sundial to count how long it's going to be.
The nice for seeing this case is this is exactly what Keeney's case was.
Yeah, it is very similar, just more tortuous.
Yeah, even though it's a 1.25 bar, you probably got a greater than 1.5 lumen.
Yeah, I think that's a good point. When you had the discussion about whether to go up to a 1.5 versus a 1.25, I always look at a burr when it goes through and say, did I get the expected lumen? Is it smaller than I expected, or is it larger than I expected? In Dr. Keeney's case, it was larger than what you expected because the bias, the guttering that took place, and the fact that you cut it up. Obviously, this looks like a 1.5 burr went through it. So with that said, I don't think there's any real need to size up to a larger burr.
And also sizing for 0.25 steps are not the way we used to do it. We used to go from the 1.25 to the 1.75, but
yeah, it's really the surface. It's not the diameter, right? It's the surface area. So
I agree. I think the issue here was perforation. I mean,
yeah.
And rota perforations are a nightmare.
Yeah, but that really all depends on the wire bias. I mean, the risk of perforation and the size of the channel that you're going to get is really depending on where the wire is. And this is why, one, it's important to use the floppy wire and not a stiff wire in a case like this. It takes longer with the floppy wire, but you're less likely to perforate. Sure. The only other thing I'd suggest, I think it's a great case, John, congratulations, but I think you've got to image these cases. I mean, these cases are so complex that, I don't even know what the true size of that vessel is.
So
there's disease you're not appreciating.
I did not put it down. I did not show you the picture. I got the IVUS catheter down past the first bend, but not the second. I did the image afterwards. Yeah. In the interest of time, I'm not showing you.
You mean at the end after the stenting?
I got it down to that midsection. I could not get it beyond there, where the balloons all got stuck.
So that makes me worried that something's not fully expanded, especially if you can't get this.
No, at the end I did.
Oh, at the end you got it. At the beginning,
I did not. After ballooning, I could only get it down to that first bend, but I couldn't.
How did it all look at the end?
There's a little bit of narrowing right there, as you might expect where it was stuff. I mean, it's about a 30% narrowing. I'd gone to pretty high pressure with the appropriate size balloon, and I just said, if it comes back, then I'll use lithotripsy. I think that's a good way to do it rather than risk any further damage there. The other thing, Gregg, to your comments about wire bias and how to try to minimize that with the floppy, the technique that was being used at the table where they're actually defeating the brake and pulling the wire back and forth a little bit is a great technique for this as well.
Well, this is wonderful. I think the vessel that you started with and the vessel that you finish was totally different. So congratulations. Those are chicken out type of lesions, my friend.
So Pedro, I started pulling out my database and selected a case from 2012, 2015 for a utterly meaningless conversation, culprit versus a complete vessel, really. At the end of it, you have to really decide, are you going to do it next day or next week? So I think the complete trial has clearly... So instead, I just pulled out 2 consecutive cases I did 2 days ago, just before coming here. And I think which actually take the entire conversation out of it, of this multi-staged versus actually doing multi-vessel STEMI. So here is a 57-year-old diabetic, 1 hour of chest pain, and almost always these people present at 1:30 in the night. So no other history needed, nothing at all. Here is his EKG. And I mean, you can have a discussion here what I'm going to find. I don't think there is going to be much doubt. You will have, I mean, there are going to be more than one culprit lesions here. I can't. Looking at the EKG, I can't make out. Is it going to be the LAD or is it the circumflex? Probably both of them. Is the right coronary artery, but any welcome to discuss if you want. But here is the, so this is what I find. There is somewhere around here should be a channel of the LAD. And again, this is also a lesion of the circumflex, and we can go back and look at the EKG. And again, always has been a principle to go after the LAD. That's the one which kills, and not sure it's going to be easy or the channel to find, but
and just for, if I'm doing this case, I'm thinking about Impella to start, but not maybe, I mean, an EDP, you had an EDP or an LV gram?
Look, exactly right. On the other hand, I have always maintained nothing you need more than quickly open the culprit vessel. I mean, here, young patient having crushing chest pain. So all of your, this thing is exactly right. So no, I've never ever worried about labs or anything quickly. All you need is a EKG to make a decision. Move the patient onto the cath lab. Again, all that could be done. So here is the first effort. Let's see if the LAD can be wired, and in the meantime, take a quick non-selective picture of the right. So right is not an issue. So I've got two culprit lesions, both the LAD and the circuit straightforward. But here is the LAD, which would be more of a challenge. And this is a hydrophilic wire, extra support choice PT, and didn't really require much. It's there in the circle, in the diagonal, moved it quickly down to the LAD, single pass with the export catheter, and this is the result. Proceeded quickly to the circumflex, and that was a piece of cake. Same wire. I often have said that, if ever I'm doing a second lesion, it has to be relatively simple so that you don't prolong it. And one of the things I use is that, look, if it is simple enough, you should be able to use the same wire. So relatively straightforward, but patient presenting with dual culprit lesion, a multi-vessel STEMI. So here it is 24 hours after that. This is at a little more forgiving 11:10 in the evening, and this is a younger patient, 47-year-old, again dual antiplatelet started. This is the EKG, a little easier task than the first one. Yet, in addition to the anterior wall distribution, there is going to be something in the inferior infralateral, mild ST elevation here in V5, V6 also, but clearly there is something happening also in the RCA distribution, probably something a little more subacute, Q waves. Anybody wants to speculate what we are going to find, what to do? I mean, multi-vessel or culprit only?
The pain was like 1-2 hours. Is this
very, very unclear? Which is how I wrote uncertain. I mean, often the classic. When did it start? I've been having it, but even 4 hours before I was not really well, so I cannot pinpoint. Very good question. Looking at his EKG, I can tell you it has been going on for a while. I mean, he already has some
like
Q waves. Yeah,
like a brain infarction or something, recurring angina on a previously
Wonderful.
infarcted territory. Yeah.
Great observation. John?
You have a rightward axis a little bit, right? Does it look like on your EKG?
Yeah.
Somewhat of a rightward axis?
Yeah.
Okay, so you have minor ST elevations. Is the troponin positive?
Oh, yes.
Very positive?
Yeah, look, I knew that later.
Okay.
Immediately at that time, he's just presented, moved him on. I didn't have the result right away. But subsequently, we got the results back by the time. Yes, it was.
Okay.
Yeah, it's interesting that the R waves are gone from V1 to V4 and V5 and V6 very small.
I mean, it looks like something right ventricular.
Okay, so let's see what we find. So this is, here you go. There's the occluded LAD and there is a occluded circumflex. And at this moment, I would normally stop here, take a picture of the right, but I'm pretty sure at this point that there should be something in the right also. Not really that sure, but so here you go. Once again, with the same principle, try to open the LAD first. So this is again a hydrophilic wire and opened up very easily, and that I think is a 3.5 stent. Decent result in the.
Nice
And
flow.
now this one is, so the circumflex is the one which is a lot more trickier. And also there is a pretty large OMB which you kind of see. It's kind of following this track. You'll see it in one of the views. Looks a pretty, there you go, kind of have a feeling, but keeps tracking into one of these smaller vessels. Tried to use a parallel wire technique, thinking you can get it somewhere here. There is this occluded vessel which should be recanalizing somewhere here. And around this time, you start having this feeling, look, and this to me is the real purpose and the beauty of discussing this case. I mean, here is a patient comes with the anterior wall MI. You open that, everything is looking good. Now I'm chasing this, but let's see. I mean, there is also a EKG, some suggestion this may be another important lesion, but exactly the observation which Dr. Moreno made, there was suggestion that this is something subacute or even chronic. So continue trying. You have a sense there is a place to place the wire, but finally, eventually, I gave it up. Now went ahead and dilated this. Not sure how much this would really have helped. It's a relatively small vessel, and but this is the final result. I have opened this, but clearly this is something the OMB which will require, and of course was somewhat surprised. The RCA is just fine, and took a short hand injection of about 7 cc's. The LV function, of course, he's taken a hit all over. And so how exactly did these two patients did? So here is their follow-up. Both patients discharged home prior to my coming here for this meeting. Both of them did fine. Door to balloon time for the first relatively easy one was 41 minutes for the LAD lesion only, and the second one a little longer. Thank you so much. Happy to take questions.
Fantastic cases, Dr. Mehta. Thank you so much.
So I'm going to show you a case here that's first in man. I thought we'd change it up a little bit with what we're going to talk about. They asked me to talk about a CTO. This is a case done about a week and a half ago down in Paraguay with a new device, and hopefully something that's going to be novel, that's going to change the CTO techniques that we have. We've had very little since Stingray came out with years ago with dissection reentry. This is looking at CTOs that are, difficult CTOs, not JCTO 0 and 1 kind of things that we've been maybe looking at or talking about, things that are going to require advanced techniques with either ADR or retrograde techniques. It's a device that I'm part of the founding group of this. Basically, the advisory board on that is Dimitri Karmpaliotis, Bill Lombardi, myself, Dave Kanzari, and Mike Wyman. So I'm going to show you what the concept behind the device is. This is the actual case in Paraguay. This is about a week and a half ago. You can see it's a proximal CTO occlusion, not terribly long. Previous failed attempt to be a JCTO of maybe 1 or 2, depending on what you thought of the tortuosity. Very difficult cap to get through. You can see we used techniques, typical dual guides, came in. We're able to dissect into the vessel proximally, unable to get anywhere downstream due to all the fibrous tissue. Push the knuckle down there. You can kind of see a track in the vessel, still unable to get anywhere. So we ended up fracking this with a Carlino here. And you can see we've injected contrast into the subintimal space. While this loosens things up, it defines the anatomy in the course. It also has the counter effect of creating a hematoma. in the subintimal spaces, which is why we fail on these CTOs. This is the mechanism of failure of antegrade dissection reentry. You can see again, we're unable to progress with push more contrast, basically absolutely destroying this blood vessel on the proximal end of things. You can see now it's pretty well demarcated where we're going, but at the same time, this is the negative process that we always end up going through when we do real difficult true CTOs. And this is what happens. So before you can see the visualization come all the way back to the proximal vessel, and now we see what we see over and over and over and over with CTO PCI is our visualization is stopped. We're not able to do reentry the way we used to be able to do reentry. And this is all a result of a hematoma formation. And this is what happens is you develop a hematoma in the subintimal space and it ends up collapsing the true lumen. And so you end up with a scenario where the true lumen folds over. You've never seen IVUS pictures like this, but it's an interesting thing to look at. The true lumen folds over. You end up with a situation where you have the subintimal space is the predominant amount of the material here, and the true lumen is very encapsulated. This is an IVUS in the true lumen just to demonstrate what you're looking at. This is why we fail on stingrays, because you're floating around in this capacious space. And so when you go to stick, you don't hit the true lumen. What you'd really like is a situation like this where the true lumen is nice and engorged and you have a small subintimal space, and then anybody and their mother can stick the true lumen because it's almost impossible to miss because you're so appropriately positioned. This is a catheter that we designed to do this. It's a little bit larger than a regular catheter. It's a 3 French catheter with multiple exit ports. Allows you to have a wire in place at the same time that you can apply suction via wall suction, penumbra pump, or a syringe. All apply about 1 atmosphere of negative pressure through a 2E side catheter. It has 6 exit ports on it, and so you can rotate the ports and you can look straight through them and you'll get an O shape, or you can look at it from the side to side, you get an X shape as you rotate it. It's a torqueable catheter, very similar to a Corsair Turnpike. And you can exit each of these ports very freely as opposed to the current Stingray model that you have. And the concept being here that when you would enter the subintimal space, you end up with this bleeding hematoma. That's the enemy of all these procedures. It's the reason why we fail on these procedures. You lose your visualization. And the concept would be here that as the catheter's passed down, you apply aspiration. You'd be able to reoppose this flap up and then have a simple stick into the true lumen. And that's, yeah, it does look good on animation, doesn't it? Can you pass to the next slide? It's not advancing here. I got it. Forget it. So this is what you're looking at in real life. So this is you're never going to see this before. So this is when you have the hematoma forms, you get pressurization. The true lumen collapses. You apply this suction and watch this unfolding. This is pretty remarkable. And it just re-expands it right back out. And you go right back to the scenario. So here's your catheter sitting in position, ready to do that stick. Here it is with this big knuckle downstream. Again, we've lost visualization from the other side. This is the actual case. And this is pre-aspiration. So if you look here, we see the picture from the other side. The filling stops proximal to the catheter and doesn't get up beside it, so we don't know where we're going. Apply just 10 seconds of aspiration with the catheter. And you can see the filling sucked all the way back up beside the catheter and all the way up to the side. So you once again can see where you're going. So you have basically a scenario where pre-aspiration, you only got to there. Post-aspiration, you can see it ride all the way up beside the catheter. Makes it very easy. So the stick is simple. You know which way you're going. Use a sharp wire, stick into the true lumen. You've overcome the hematoma that you failed with before. And pretty simple process to go ahead and stent at that point in time and optimal results. So it's new technology. It's not approved in the U.S. Yet. Got approval from Dr. Sharma, showed here today. We're looking at 510K probably in late August, early September. So hopefully we'll have it for some of the live courses coming up. But I think it's really going to change CTO PCI. I think we have the ability to be much more liberal with our dissections, knowing that we can fix the dissections readily and absorb the hematoma that previously was really struggling with. And I think it's going to largely reduce a lot of our retrograde.
Very impressive. Very beautiful device. Makes a lot of sense. Decompress the hematoma, the lumen comes back, and then re-entry. So the presentation is open for discussion.
Well, great case, a fantastic device. I actually had a very similar case in a STEMI.
With aspiration as well? Yeah. It's not all that different than straw, the conceptually of what we do with straw. The issue has been trying to get a second catheter down there to get adequate suction, because the Stingray balloon that we use for straw really just doesn't have the lumen to allow you to get significant hematoma removal. This is a kind of a balance between, it's a cubic increase by how much aspiration you get when you get bigger, but it's also tracking and other things that you compromise if you're going to do that. I think we're sitting on the optimal size here where it's not too ridiculously big to put in a corner. You can still trap it out with a 6 French guide and those type of things.
Look, the reason I mentioned that is because you are presenting this as a CTO device, whereas I think there are going to be several other applications.
I agree with you. I think in iatrogenic dissections that you have in the cath lab, I think it's going to be a wonderful tool to be able to aspirate that and reestablish flow.
Yeah, the other comment is that you're stenting in the tunica media. So really the intima is out. You exclude the intima, you re-enter. And that was the model we used with Barimon in his chamber. De-endothelialize, separate the intima. It was a most thrombogenic substrate. But I think it's very well established now that the re-entry works very well.
Yeah, I think no question. I mean, our colleagues, Spratt and Simon Walsh and those guys showed beautiful OCT data demonstrating that with 1-year follow-up angiographically. So.
Is the limiting factor how much you can aspirate on that?
Yeah, you can aspirate about 1 cc every 10 seconds, which, if you think about it, is in that space is a lot. Yeah.
What's
the Traverse.
Traverse. And you said it has how many different ports distally?
Currently has 6. Probably going to arrive on 4.
Okay, so arrive at 4, and they're 90 degrees around,
they're 180 opposite of each other, then 90 offset, so that you have an exit port. But it's a torqueable catheter, so you can always place the port where you want it to be.
What's the profile and how stiff is it?
3 French, and it's very similar to a turnpike.
So I love the concept. It really looks great.
Thank you.
Thank you so much. I think it's
Bill, a quick one more comment here. Can you use one of the ports to even inject something?
You can. So it's really nice. We actually did that in Paraguay as well. You can do angiograms with it. You can deliver medication without giving up your wire. It's large enough to put 2 wires through to, if you want a parallel wire as well. Yeah.
So this is something probably a lot of you don't know about. And actually, I thought this was a data talk. I didn't know it was a case because you wrote emerging data in the title. So it's going to be some data, but I will show you why we need this with a bad case. My disclosures. You saw some nice STEMI cases with short door to balloon times by Samir. But despite that, we do a really pretty poor job in salvaging myocardium. And this is data from Horizons AMI, where we did baseline and follow-up angiograms at 13 months. So we did acute angiograms prior to the STEMI PCI, and we look at the global improvement in left ventricular ejection fraction. And in about 60% of the cases, there's actually no change or a reduction in the ejection fraction. And when there is a change, it's like a 0.5% improvement on average. And so let me show you. This is the problem. Oops, forward. This is the problem. So poor recovery of LV function in patients without cardiogenic shock is really the number one issue we have in primary PCI today. So here's a 49-year-old man who presented with crushing chest pain for 90 minutes. So reasonably rapid time, he ended up in the emergency room. And here's his baseline angiogram. Total thrombotic occlusion of the proximal LAD before the first septal perforator. And here's his baseline left ventriculogram. And I still do baseline LV grams and recommend this before all procedures. It's really, really helpful. Occasionally, you'll find VSDs or other mechanical complications of AMIs, aortic dissection. You'll understand what the left ventricular end diastolic pressure is. And as long as the renal function is not too bad, it takes 5 minutes. And you can see his whole anterior wall is not moving. Apex is not moving. Distal inferior wall is not moving. Slightly dyskinetic at the apex, etc. Okay, so his door to balloon time is 67 minutes. Okay, so not too bad. And here's the post-PCI result. You get great TIMI-3 flow. You can see the stent and the proximal LAD. And we brought him back at 13 months. He was in the study, so for routine follow-up angiography, stent is widely patent, TIMI-3 flow, no side branches are missing or anything. And so remember, here's his baseline LV gram before we did the primary PCI, and here's his LV gram 13 months later.
But Gregg, following your teaching of the blush, how do you feel about the blush?
Right, exactly. So we get the epicardial coronary artery open, very high rate, 85 to 90% TIMI-3 flow after primary PCI. But as I'm going to show you in the next slide, we only restore myocardial reperfusion in about half those cases. And as a result, we only get normal ST segment recovery in about 50% of cases. So, I mean, look at what happened to this patient. This patient ended up in NYHA class 2 heart failure. And you can see some thrombus actually at the apex. And his ejection fraction didn't improve at all. In fact, it went down a little bit because he doesn't have the compensatory hyperkinesis at the base anymore. So this is really our biggest problem. And we and others have shown from this large pooled analysis of infarct size measured within 3 to 5 days after the infarct and then 1 year outcomes, that there's a hugely powerful relationship between infarct size and non-shock patients and both death and heart failure rehospitalization rates. And again, this is just what we were talking about. If you look at TIMI-3 flow, this was from Horizons, 86% in all cases. This was 3,600 patients, not bad. But myocardial blush is normal in only 51% of cases, and ST segment resolution is only complete in 50.5% of cases. So we should be honest with ourselves. In about half the cases, we're not successful of primary PCI, even though we get the artery open, and that confers a survival advantage. It adds electrical stability, it prevents aneurysm formation, other things, but it does not afford myocardial recovery. So the concept of supersaturated oxygen was to basically withdraw the patient's own oxygen from the femoral artery after the procedure, once you've got the coronary artery open, so it doesn't delay reperfusion at all, put it into an oxygen mixing chamber and pump it up. Pump patient's own blood up to 760 to 1,000 millimeters of mercury of oxygen, and then reinfuse it into the coronary artery. And initially, we did this through a tracker-type catheter right into the coronary artery zone of the myocardial damage. And this basically was trying to replicate wound healing, what was done in hyperbaric chambers. And believe it or not, there were some early studies where they put STEMI patients in hyperbaric chambers. And there was actually early data in about 29 patients that myocardial recovery was improved. But it's not really reasonable to put a STEMI patient into a hyperbaric chamber. So the concept here is that you're actually infusing the damaged tissue with hyperbaric oxygen at very high partial pressures of oxygen, similar to what would be done in a hyperbaric chamber. And a lot of this work was done by Richard Spears in Detroit, and he showed in animal models that after 60-minute animal occlusions where you get these transmural infarcts, if you then do the 60-minute occlusion and then infuse supersaturated oxygen, you essentially eliminate the infarct. A lot of basic science data, but I won't show you that now. So we ran a randomized trial called AMI-HOT2, and this is a pivotal trial that was designed to show reduction in infarct size, and it was actually a positive trial. This is the only positive trial of any therapy so far, a pivotal, adequately powered trial to show reduction in infarct size. So this was all in LADs, proximal and mid occlusions of LADs, TIMI 0 to 2 flow at baseline, patients presenting within 6 hours. And you can see the control infarct sizes were 25% of the left ventricle, and that was reduced by supersaturated oxygen to 18.5% of the left ventricle. This was a Bayesian study. It was highly positive. And the median of the differences was 6.5% of the left ventricle. That would be expected with a couple thousand patients to translate into about a 25% reduction in mortality.
And Greg, the baseline size of the MI was similar in both groups?
Yeah, similar in both groups, about 25%. Well, this again, we didn't know. There was no baseline. We just had a 3 to 5 day measure of infarct size, because these are primary PCIs. The problem with supersaturated oxygen, we initially had some safety concerns. The overall MACE rates were not significantly different, and in fact, we easily met the non-inferiority criteria for safety. But there was some extra bleeding because, again, this was all done from the femoral artery, and you needed to use a larger catheter or a second stick to draw the patient's own blood. And that led to some increased local vascular bleeding complications. And so FDA wanted us to come up with a better technique, or wanted the company, which is Therox, to come up with a better technique that was a little safer. And so this process was then turned into what was so-called optimized supersaturated oxygen, where basically after the PCI, the supersaturated oxygen is just given through a diagnostic catheter at the origin of the left main. So now it infuses both the LAD and the circumflex artery. and the infusion rate was increased, and the time of infusion was decreased from 90 minutes with the old way to 60 minutes. So this is a 60-minute infusion. But basically, now that you're doing it through a diagnostic catheter, the sheath can be substantially smaller. And we did basically 100-patient safety study, and the FDA wanted to see a performance goal of all these different MACE events at 30 days of less than 10.7%. That was based on literature and propensity matched patients, and we were at 7.1%. In fact, there were only a few TIMI minor bleeds. There were no TIMI major bleeds, and there were no. The incidence of target lesion failure was only 1 patient, or 1%. So on the basis of this, and then we had this was not a randomized trial, this secondary study, but we did a propensity matched analysis compared to the Infuse AMI trial, which was done at close to the same time, exact sorts of patients. And in Infuse AMI, which didn't use supersaturated oxygen, we had a 12.3% incidence of death or new onset heart failure hospitalization at 1 year, compared to 0% in these 100 patients. Not randomized, so take it with a grain of salt, but promising. And you can see the reductions were in death and heart failure, with no differences in myocardial infarction, TVR, or stent thrombosis, and you wouldn't expect differences from this therapy. So the bottom line is that on April 2nd of 2019, the FDA approved supersaturated oxygen therapy for the treatment of patients with anterior MI undergoing primary PCI within 6 hours of symptom onset. And it's now readily available for you to use in your cath labs. Again, right now we recommend it only in anterior myocardial infarctions with angiographically proven proximal or mid-LAD TIMI 0 to 2 flow at baseline within 6 hours, then a successful PCI result. TIMI 2 or 3 flow post-PCI. This isn't the last you'll see of this. The company's supporting a post-approval randomized trial in 434 patients to replicate the reduction in infarct size, and using a composite hierarchical and clinical endpoint to show reduction in all-cause death, heart failure hospitalizations, or infarct size. And we're also now exploring this in shock. So there's a randomized ISO-shock trial, which is just starting, which will be a 60-patient randomized trial looking at supersaturated oxygen in shock. So anyway, this is a new therapy. It's the only one approved right now, and the only one that's been shown to reduce infarct size. And I think it's very reasonable to consider in these very large infarcts without shock at baseline that still have a high rate of death and heart failure hospitalization despite timely primary PCI. Thanks. I'll stop there.